Welcome, everyone. I'm Tammy Alexander from the School-Based Health Alliance, and thank you for attending our webinar today, Achieving Health Equity through School-Based Healthcare. And we want to thank the Colgate Bright Smiles, Bright Futures program for partnering with us for this webinar today. So if we go to the next slide, we'll see that there's just a few housekeeping pieces I want to take care of. As this is a webinar, you will all be in listen mode, and we will run the show that way, but you can ask questions in the Q&A portion of the Zoom meeting, and you're probably all very experienced at this. But if you see the yellow circle, there's the Q&A there. And if you want to chat to anyone, please use the chat function and make sure you mark panelists and attendees. We will hold all the questions till all the panelists have had a chance to speak, and then we'll try to get through all your questions before we sign off. If we do not get to all the questions, we will try to get them answered, and we have all your contact information, and we will send it back out to you with the answers. So before we get started, we want to do a quick poll. So Ufoma's going to pull up the polling thing, and if you'll take about 1 minute to answer the poll questions, we'd really appreciate it. So you'll see them on your screen. How knowledgeable about health equity are you currently? And what's your professional association? So take just a minute to do that. And Ufoma will let us know when we see a good response rate, and she can show us the results of the poll. Sort of fun to know who's on the webinar today. You can always go to your participant button and take a peek at who's attending. And so from poll 1, 54% really believe that they are, they're moderately knowledgeable. Working in the field of education and health, you probably do have some basis and awareness of health equity, and it's very significant in the work that we do. And if you can scroll down, Ufoma, to the second question, we can take a look at the professional associations. Oh, I can scroll it. Oh, I didn't know I could do that. So we've got a mixed bag of people today. It's great to see that. It's definitely takes all of us to do this work to make an impact and make a difference. And so it's good to see the diversity that we have on the call today. And I think we'll close the poll and we'll go to the next slide. And I just want to welcome you again, once again, and I'm going to turn it over to Robert Boyd, President and CEO of our School-Based Health Alliance. And happy to have Dr. Jillian Barclay as our moderator today of the panel. And with that, Robert, it's all yours.
Good afternoon, everyone. Thank you for joining us for our webinar, Achieving Health Equity Through School-Based Care. My name is Robert Boyd, and I am the CEO of the School-Based Health Alliance. We want to start with a thank you to all of you who are serving on the front lines in this pandemic. Your jobs were hard enough before this worldwide outbreak. Nonetheless, you held the line. Thank you for taking care of our kids. We also want to thank Colgate Bright Smiles, Bright Futures for their support of this event, their support of the School-Based Health Alliance, and their commitment to healthy kids and healthy schools. We also want to thank our panelists for taking time from their busy schedules to discuss a topic for which they're all passionate advocates. Our theme for this event, Achieving Healthcare Equity Through School-Based Care, is a primary focus at the School-Based Health Alliance and will be the theme for our 2022 National Conference. We'll have more details on that for you soon. We know that due to racism and other oppressive systemic societal structures, children from low-income and racial and ethnic populations in the U.S. often experience worse health, miss more school days, and are less likely to access healthcare. They are also more likely to have problems with vision, oral health, or hearing. Increasing access to comprehensive services where the youth are improves educational and health outcomes in schools. But don't take our word for it. These facts are well documented by the CDC's Community Preventative Services Task Force, and they've never been more important than now. With childhood vaccinations on the horizon, it will be those of you working in schools and community health centers that will be called upon to deliver those vaccines, particularly in low-income and underserved communities. No one understands that better than our moderator, Dr. Jillian Barclay. She's worked in government, the private sector, philanthropy, academia, and international development. Jillian understands that healthy kids are a key to a healthy economy. A dental surgeon by training, she also holds master's and doctoral degrees in public health. Presently, the vice president for global affairs, global public health and scientific affairs at Colgate-Palmolive. Jillian is a true champion for our kids and for all of you who work with the underserved. It's my high honor to introduce Dr. Jillian Barkley.
Thank you, Robert. And I'd like to thank everyone for joining us for today's panel and our discussions on achieving health equity through school-based healthcare. So we are really fortunate today to have a distinguished group of panelists for today's presentations and the discussions after their presentations. I know that you've already seen their bios, their detailed bios when you registered for this event. So I will just take maybe 15 seconds to introduce them. Dr. Professor Pedro Noguera is the Emory Stoops and Joyce King Stoops Dean of the Rossier School of Education and a distinguished professor of education at the University of Southern California. Mr. Jose Munoz currently serves as the interim director for the Institute for Educational Leadership. And since 2017, he has also been the director of the Coalition for Community Schools. And Dr. April Joy Damian is the vice president and director of the Weitzman Institute, a research, education, and policy center dedicated to primary care innovation and transformation, particularly for the underserved. So as Tammy pointed out in the beginning, our panelists will speak first. They will speak in total for about 40 minutes. And after that, after all their presentations, we will begin questions and answers and discussions. And please remember to use the Q&A box for your questions. And when you write your questions, please indicate the panelists to whom your question is being directed also. So in order of presentations, we will begin with Professor Pedro Noguera, then Mr. Jose Munoz, and Dr. April Joy Damian will be the last panelist to speak. So let's begin the panel and welcome Professor Noguera.
Thank you, Dr. Barkley. And it's great to be with all of you. Greetings from Los Angeles. Very happy to be part of this discussion. I want to start by just stating the obvious, which is schools are an excellent place to address health needs because they have the children. But I also want to point out the challenge. Schools have other responsibilities beyond health. Namely, their job is to educate kids. So the real question is, how do we integrate this work in a way that is consistent with the mission of our schools? So if we could advance the slide, please. So I want to raise a few questions for you to think about. We've had this major disruption created by the pandemic. The real question we face is not to go simply back to the way it was, but can we make schools better and more responsive to the needs of students than they were before? Second, can we shift the paradigm that influenced the way schools operate so that equity and health and the social and emotional needs of children are at the center of our work? Again, not to suggest that academics are unimportant by any means, but they have to be, as we all know, sick children don't do well in school, nor do hungry children. What are the barriers to equity at your own school, if you're working in schools, or if you're in the neighborhoods where you live? And how do we make sure that schools receive the support they need in this work? And then finally, how do we build capacity? Because, as I said, it's asking a lot of our teachers for them to be psychologists, social workers, as well as surrogate parents. And so they're going to need help in order to do this work well. Advance the slide, please. So as we know them, schools are often characterized by deep disparities in achievement that correspond to health disparities. This is very important. The same children who are struggling typically academically come from families that are often struggling economically and faced with a number of health challenges that were exacerbated by the pandemic. And I'm including here mental health challenges as well as things like diabetes, asthma, etc. We know those children are also most likely to be disciplined and punished compared to other children, often because we focus on the behavior, not the cause of the behavior problem. If you don't address the cause, the behavior doesn't change. If a child is acting out because they're abused or neglected at home, punishing them will not change that. If a child is acting out because they're bullied or because they are depressed, again, punishment is not going to resolve that situation. We too often have had a narrow focus on achievement at the expense of the other needs children bring, and we rely too often on pressure and fear as motivators in schools. And there's often a punitive culture that comes from the way we think about accountability on schools. Advance the slide, please. Poverty is a serious challenge facing our society and our schools especially. Over 50% of children in America come from families that qualify for free and reduced price lunch. That means their families or incomes are low enough that they need the subsidy of food and often breakfast as well that comes in school. So already what we're saying is that schools are the most important institution in this country for responding to issues that arise as a result of poverty in this country. And that includes, again, things like food insecurity. Advance the slide, please. Toxic stress, advance again, impacts learning. We've just become more and more aware of how many children experience trauma and adverse childhood experiences. It affects attention, memory, inhibition control. Advance the slide, please. One more time. And it also is associated with higher rates of poverty and impacts the development of children's brains. Now, I want to be careful here. This does not mean that poverty is a learning disability or that children who've experienced trauma cannot be served. We just have to recognize that this is a factor facing many of our children. And I should add, there are many children who are not poor who also experience toxic stress because of the society we live in. There's so much violence in this country. Advance the slide, please. So the real issue is, can schools play a role in addressing wellness and academic success? And what will it take for that to happen? My argument is that we've got to make equity central. That means acknowledging differences in children and their needs, responding proactively to their academic, social, and psychological needs. It's about being fair, and most importantly, speaking out when we see children in need and when we see they're being denied the opportunity to learn. Advance the slide, please. This diagram shows us the difference between equality, treating everyone the same, and equity, where we acknowledge that some children have greater needs, and so we do what we can to respond to those needs. Advance it again. What we often don't see is that the most privileged children, that is, children who come from more wealthy families with educated parents who have more time on their hands, have enormous advantages, including health advantages. These are the children who get to see a dentist or who get eyeglasses when they need it, whose families aren't dealing with challenges related to poor nutrition. So when we have an equity lens, we not only see who's being left out, but also who's being privileged. And our work, therefore, is, advance the slide, eliminating the barriers that make it impossible for children to participate fully in their education and society. Now, I want you to think about that, because as we eliminate those barriers, it means all kids benefit. This is important because too often people see equity as favoring some kids over others. All children benefit when we think holistically about the needs of children. Advance the slide, please. One more time. This wheel, if you're not familiar with it, is developed by the University of Illinois, Chicago. Their Center on Social and Emotional Learning has talked about why focusing on the social and emotional needs of kids helps to advance learning in other areas, increasing self-awareness, self-management, responsible decision-making, relationship skills, social awareness, and that benefits the classroom, the school, the community. What that means is we have to be very intentional about teaching things like kindness, empathy, integrity, right? Respect. These are, you cannot assume children know these things, and rules do not teach them. Values are more important than rules. Rules are only enforceable when adults are present. The goal of discipline, in the words of Lawrence Kohlberg, is to teach children to do what's right even when adults aren't looking. Advance the slide, please. So the typical barriers are bias towards children, the belief that some children are inherently inferior or broken or damaged. A narrow-mindedness also is a barrier when we see teaching and learning is disconnected and teachers are not taking responsibility or for the needs of their students who are falling behind. When there's a punitive mindset, this gets in the way, and when there's unequal access to support. That's why my hope is that as those listening today are also thinking, how do we get schools the support they need so that it's not just up to the schools to do this important work? Advance the slide, please. So we want schools to be places where a child's race and socioeconomic status do not predict how well they will do. Think about what that means. That means that all kids, regardless of their backgrounds, get an education that not only stimulates and challenges and uplifts them, but that they're in schools that can respond holistically to their needs. It also means that their culture and language is respected and it's treated as an asset, not something to be negated and through assimilation. And then finally, we're working in partnership with community organizations and most importantly with parents. And I can't say enough about how important parents are in this work to ensure that the needs of children are met. Advance the slide, please. So this is what the research shows schools should be focused on if they're going to improve over a sustained period of time. They have to have a coherent approach to instruction, which means teachers are clear about what children should learn and what to do if they're not making progress. Secondly, ongoing development of the professional capacity of the staff. The skills of the staff have to match the needs of the children. When that alignment occurs, schools improve. Third, strong parent, community, and ties. So there's reinforcement at home for what's happening at school. Fourth, a student-centered culture that affirms the value and importance of learning and of children, not an adult-centered culture. And fifth, strong shared leadership organized around a common vision. If we do these 5 things, and the research is very clear, all schools can be much more successful than they are now in meeting the needs of children. Advance the slide, please. I'm running out of time, but this is a very important point. We are never going to get there by blaming schools. We have to build the capacity of schools and teachers, which means we have to provide the right professional development and the right supports. Advance the slide, please. So we're going to have to make sure they can do this whole child work, that we know how to support children when we rely on distance learning, that there's a sense of cultural competence among the staff, so they can work with all kinds of children regardless of their culture or language, and that we've got to move towards being much more responsive than we are. I think I'm out of time and I don't want to cut into Jose's time. He's my friend. So I will stop there. Thank you for the opportunity and look forward to the questions and answers.
Really appreciate you, Pedro. I want to also thank Robert Boyd for having us on as well, and Dr. Barclay for moderating for us in the School-Based Health Alliance, for being such a great partners in this work. Pedro, you made me reflect, actually had me distracted about what I was even going to present on, because it was so powerful what you were saying here as a father of 5 and growing up in the inner city with a single parent and other siblings around here. Is so much resonated with me in my own life that you were bringing up, that decades later, I'll just say that in regards to my age, it's still very relevant today. So what I like to talk about a little bit is about really achieving the health equity through school-based health care, just as the title states right there. And what I love about that is like school-based health care. It's like, what is school-based? That's obvious part. But what is health care? And we often think about just shots in arms or stethoscopes or thermometers. But this is also what Pedro was highlighting, also the development of relationships, the connective tissues and bonds that we form with community members throughout our lifetimes, and how that supports us as we go through trials and tribulations of our own life, but also someone to celebrate with us and help us through to get to the levels that you see us on the screen right now. We didn't start off in this space. Every single one of us has our own personal story. Pedro's and Dr. April, you as well too, and mine as well. But let me talk a little bit about the how. Before I do that, just so you know who I am and who I'm representing. I am the interim director for the Institute for Educational Leadership, yes, and the director for the Coalition for Community Schools. A little bit about IEL for short. Since 1964, we've been championing the need for leaders at all levels just to shake off those institutional constraints that prevents us from this work. So we can actually work together to address the needs of all children, as Pedro mentioned as well too. Over time, as we've helped define at the national and at the state level policies in education and workforce development that enable leaders to build collective strategies that and get real results in real communities. We've assisted folks doing the work to implement quality practices by connecting them together, really building community in their field, leading to better outcomes for young people. Our biggest purpose, though, is to really just support communities as they build these equitable systems around racial, disability inclusion, and economic equity goals that they may have. And we do that at the intersections of education, health, and employment. That's a little bit about us. One of the things we were asked to kind of share our philosophy, and this is pretty relevant from Pedro's conversation. If you go to the next slide, I just share with you just my view on this, what health equity means for me. And that's caring for those who are really heavily burdened and oppressed, that we do it sufficiently enough, not just a little bit, not just programmatic, not just a few provisions, but sufficiently enough that we actually create paths for them toward prosperity, towards wellness, and towards their own well-being. Breaking down those words a little bit, that could be pretty jargony. So prosperity, we often put in an economic bucket, but if you look at the root, the Latin root word of prosperous, it actually means favorable. Sometimes prosperity is just other folks, how they look more favorable at us. When you bring people together often enough, and we get to know each other inside of a school, especially, that there's a sense of care that is going on that helps us make us look favorable among others. Wellness. The definition of wellness in the dictionary says the state of being in good health, especially as an actively pursued goal. So Pfizer puts it this way: wellness is the act of practicing healthy habits on a daily basis to attain better physical and mental health outcomes, so that instead of just surviving, we're thriving. So this is really about our overall wellness from a physical, emotional, and mental wellness we're speaking of, and then well-being. The American Psychological Association puts it this way: a state of happiness and contentment and low levels of distress, overall good physical and mental health, and outlook or good quality of life. I really love that framing. It's kind of a trifecta framing for me, at least as the presenter right here, of my view, how that blends over into the work and why I even came to IEL to work with the Coalition for Community Schools. I love the vision that the school can actually be the center for creating this flourishing community where everybody belongs, they work together, and they thrive. We're really talking about a state of being when we talk about school-based health care. Pedro mentioned some data earlier of over 50% of our students. That's pre-pandemic also. 50% of our students were living in poverty. 50% of our students who were going through traumatic experiences caused by poverty. Not just poverty for the lack of funding, but poverty of money, but the lack of poverty also of relationship, of what that does for individuals when they don't have opportunities to provide care for their children. They have opportunities to actually build their own capacity in their work. So we have reached a tipping point the wrong way in our country, where over 50% of our young people that attend school are living in conditions and have been marginalized, and maybe we don't even have the opportunity to participate in designing their own path forward in building community with each other. So talk about school-based healthcare. One way that I have grown to love and care for and now get an opportunity to lead is community schools. So if you go to the next slide, there are communities across the country right now practicing community schools. I'm going to go into deeper on how community schools could be leveraged, but first, let me tell you a little bit about community schools in themselves. These are buildings and facilities that actually bring people together. They can work collectively together to actually design their own outcomes in future. They can create opportunities by partnering with local organizations. They create better bonds between households. They create better bonds and extend learning past the classroom where things could actually be applied out in their community. We have a large goal that the School-Based Health Alliance is a part of. That's 25,000 community schools by 2025. Let me give you some of the reasoning why, some of the practical reasons why here. Name a public facility that has more communication power than a public school. Name any facility. I like to say church, but we only go once a week, if that at all. Name a place where it has the most communication power, where anytime you design a city, a town, any family living quarters that goes around it, you are naming a school. That school automatically has at least 40% of the days out the year an opportunity to engage people back and forth and communicate with them. There's a growing movement right now of community schools. We say 25,000 by 2025 because we need to shift the tipping point towards young people who are moving towards poverty and shift that where we actually disrupt generational poverty. You may have started there, but working together and along somebody walking beside you doesn't have to stay that way. So this is a regenerative approach in community schools. There's just about 25,000 school-wide Title I schools across the country. Pedro described it earlier where those are where large populations of young people who qualify for free and reduced lunch actually attend the school. There's almost 99,000 public schools across the country. So what we're asking for here is for us to create a tipping point across America where 25,000 schools, about 25 to 30% of the total school population, begins to operate in such a way where folks are connecting, they're communicating with each other, they're collaborating across beliefs, across race, across even classes. As Pedro mentioned, yes, there's people who don't live in poverty who actually have needs as well, actually go through trials and tribulations as well too. We're asking for 25,000 of those places. How will that help us increase or advance health equity through school-based health care? If you go to the next slide, I'm gonna go a little bit deep into this. Forgive the graphics. I'm not a graphic artist. So here's a little graphics explaining this a little bit. This is how we can harness and put what Pedro talked about into action. So your far left, every place I described neighborhoods, there's homes there. Well, in those homes, there are already a number of people who have the historic wisdom of not just how their families grew in that neighborhood, but how their neighborhoods were shaped. They have the will, they have the gifts of the head and of the hand to contribute to the larger population. And they have a cultural wealth. Our diversity is our strength when we look around the country right here, and we can't neglect the wealth of culture inside of households. When that comes together, that top arrow, all of that comes together in place inside of a public school. That's why it makes sense. All of our cultures, all of our race, all of our strengths, all of our talents come to place. We can't just focus on all of our problems, all of our trials, all of our tribulations. With that in place and connected together, we can overcome that. This is how. That schoolhouse, when they begin to connect with people intentionally and make intentional connections between people, begin to communicate more frequently back and forth between households and neighborhoods and school institutions, and coordinate and collaborate across that and coordinate that, they can then go to the bottom arrow and form these anchor institutions where leadership has all of us as professionals we love to go into and work for, to help us to think about how we re-provision, how we create our procedures, and how we recreate policies for equity. Now, it's not our role to make sure it's doing it, because we're not to actually activate that. Our role is to send that back to local communities, that top arrow going back. They are the ones closest to the work. They are the ones who are closest to the people who need support. They are the ones who dream of the opportunities that they envision for their future community. They can take those resources in that bottom arrow and then equitably distribute that across those who need it most, and create the paths and opportunities from poverty to prosperity for folks in their area. What does that lead to? The triangles. So essentially, what we want to work with community schools is move people from beneficiaries all the way to leaders, to recognize that if we have enough community schools and across any given area, whether there's one school in a rural community or multiple schools, we can then see democracy being built up, well-being across. We can see equity happening, and we can flip some of these numbers. One more slide. Next slide. What we'll ask of you is just everybody be an advocate. You can find a role and participate in this. You can advocate for community schools. You can advocate for inequitable issues, against inequitable issues. You can advocate for equitable issues in there. You all play a part in that. And last thing I'll do before I introduce April is, if you go to the next slide, is invite you all to our community school and family engagement. I call our family reunion. So put the date on there, Los Angeles, June 1st through 3rd, 2022. And can't wait to have more conversation from the questions you have. And with that, I'll pass it over to our colleague, Dr. April Joy Damian.
Great. Thanks, Jose. And thanks again to Robert Boyd, Dr. Barclay, the teams at School-Based Health Alliance and Colgate Smiles for the opportunity to join such an esteemed panel on such an important and timely topic. Pretty hard acts to follow, but I will do my best to keep you all alert and focused. So next slide, please. So as you heard from my fellow panelists, we were asked to talk about our philosophy on health equity and related work. So I chose this figure from a group out in the Bay Area, my hometown in California. Just a small shout out to really show the connections between social inequalities and health. So for me, my own philosophy on health equity means looking beyond the individual, beyond the four walls of clinical practice, and even beyond healthcare access and outcomes. So health equity to me entails looking further upstream, which is encircled in this slide. And this is where I really focus on as a public health researcher and as an epidemiologist. So by looking upstream, we can connect the dots and recognize that health disparities are inherently linked to historical, structural, and social inequalities that we continue to see the ramifications of today, and you've heard from the prior speakers. But more and more, as some of you may already be familiar, I feel like health equity has become jargon and sometimes overused, and I'm gravitating now more so towards health justice, which really treats healthcare access as one of the many social determinants of health deserving of public attention and resources. So to me, health justice and true health equity recognizes that the same patient populations that suffer from disparities in healthcare access, outcomes, and life expectancy, many of the issues which my colleagues at Community Health Center, Inc. at Weitzman deal with on a day-to-day basis, are also disproportionately impacted by food insecurity, housing instability, poor access to quality education, unemployment, and also climate change, which we're seeing more and more. So my work really entails examining what we call the built environment that has created these conditions and using real world data to solve for these issues. Now on the bottom of this slide, I also included the life course because this is something that we're taught first year of public health graduate school. And this is really understanding that how we address health equity or even health justice varies across the lifespan, right? So for example, on the one end of the life course, kids tend to spend a lot of time in schools, whereas adults spend a lot of time in the workplace and so on and so forth throughout the life course. I think it's really important to have a more nuanced understanding of population-based built environments so we can tailor our solutions to the communities of interest. Next slide, please. So I think for me, a major challenge in health equity is workforce representation. And I think my colleagues on this panel would agree that it's probably the same in education and other fields. But because I'm really at that crossroads of public health and primary care, I figured I need to focus more on primary care and the healthcare workforce. So here is a graph from a study conducted by Dr. Edward Salzberg and colleagues. They used data from the 2019 US Census Bureau's American Community Survey, as well as the National Center for Education Statistics, to look at college graduates and analyze diversity across the professions. And not surprisingly, probably to most of you, they found that people of color continue to be underrepresented across a host of health practitioner roles, which is in this graph. They also noted that the current shortage of Black, Hispanic, and Native American graduates could continue to limit workforce diversity across the country. Now, my colleagues at Academy Health are conducting similar studies on health services researchers, which I'm a part of, and preliminary data is showing similar findings. There is literature to support that a more diverse workforce will help address disparities in health outcomes in healthcare. For example, it's well supported in the literature that Black, Hispanic, and Native American practitioners are more likely to serve in underserved areas, as well as with underserved populations. Literature also supports that diversity in the workforce increases trust between patients and providers, and that having a diverse class in the pipeline improves cultural sensitivity for all practitioners, regardless of their racial or ethnic background. Next slide, please. Now I understand why I was at the end to really connect the dots, right? Because health and education, they're inherently linked together. If we go to different countries, health and education ministries are usually put together, and somehow we separate here, but I'm glad through the work of School-Based Health Alliance, of my fellow panelists, and Colgate Smile supporting this work, they're seeing the true connection between education and health really being inherently linked. So I really, one of the scalable solutions that I highlight here is that educational barriers to health professional schools really contribute to the lack of diversity in the healthcare workforce. So here I show a picture of what is called the leaky pipeline in science, technology, engineering, and math, or STEM fields. Say if we're really serious about diversifying the health professions field, then that's inclusive of practitioners, my clinical colleagues, as well as researchers like myself, then we really have to start earlier. So real efforts to train, recruit, and nurture, for example, people of color in the STEM fields, as well as health professions, must be made at all levels. So that's grade school, undergraduate, graduate, postgraduate, and even at the faculty levels. So we really should be asking critical questions such as how are current policies incentivizing investments in education throughout the pipeline? And then if necessary, implementing mandates to ensure that there are investments made throughout this pipeline. I also want to call to attention to the far right of the pipeline, and that's sustain. And I think that's where my colleagues and I are at now. And I want to note the example given by Professor Tyrone Hayes when he was an undergrad. So for nearly 30 years, Professor Tyrone Hayes was the first and only African-American professor in the integrative biology department at UC Berkeley, which is my alma mater. Now, this department was home to a significant percentage of pre-med students, as well as courses required for matriculation into medical school and many other health professions training programs. I recall as an undergrad participating in a fireside chat with Professor Hayes. And since he was an advisor to the UC Berkeley Biology Scholars Program, which invested in students from underrepresented populations, and I was a beneficiary and member of that group. And Professor Hayes shared with us during that fireside chat that efforts must not stop simply because a department, a practice, a health system has one or two representatives of color, but critical mass must be built so that single isolated individuals are not overburdened with the task of ensuring the diversity of the workforce. Further, recruiting critical mass at all levels will ensure that role models are available to support and nurture the careers of people of color. And I do want to note that everyone needs to take a responsibility for these efforts and not solely assume that a few members of underrepresented communities will automatically take on the responsibility of ensuring a diverse workforce and promoting health equity. So as Professor Hayes said, this must truly be a team effort. Next slide, please. So I want to close with a health equity success story. So as some of you may already know, I was fortunate a few years ago, or I should say several years now, to work under the leadership of former Baltimore Health Commissioner, Dr. Leanna Wen. And I served as the main principal investigator of what was an unprecedented NIH-funded research initiative, which evaluated the pilot of a citywide trauma-informed care training initiative. And this was in collaboration with SAMHSA and Behavioral Health Systems Baltimore. And almost 5 years later, so going into the present, the Elijah Cummings Healing City Act, sponsored by Council Member Cohen, was signed by Mayor Young on February 9th, 2020. And this essentially created a citywide task force to identify ways to reduce trauma for children. And I call this a success because usually there's this lag time between when you do research and when it actually gets implemented into practice. It's also a success because this task force is not solely made up of policymakers or the who's list, but is essentially made up of individuals, including pediatricians, researchers, community organizers, returning citizens, and voices of youth with lived experience. Because I must admit, even when I was in Baltimore, just for a few years, there have been people who have dedicated their lives to working on individual and communal trauma. And there are people with lived experiences who know firsthand the consequences of experiencing both individual and what we call acute on chronic communal trauma. So this is really a success because it essentially combines treetops and grassroots approaches to addressing trauma, not only at the individual level, but also at the community level, and ensuring that there's adequate funding and policies to ensure the success of partnerships across different sectors of government, and that community members have a seat at the decision-making table. So thank you for having me. I will now turn it back over to Dr. Barkley.
I'd like to thank the panelists for their insightful and also thought-provoking presentations. That, you know, when we look at the issues, these are not new issues. They have been around for decades. And I see now where they're, you know, with the combined action, the unified action of addressing health equity. And I do agree that the words are overused. I do agree with Dr. Damien, and that there are now new opportunities for solutions and to start executing solutions. So the floor is now open for questions. And there were some questions that actually popped up in the chat directly to the panelists. And thank you, Tammy, for alerting me to that. There's one question specifically for Dr. For all the panelists, as what are the greatest barriers that each of you may see to achieving health equity in schools? What do you perceive as the greatest barriers?
So I'll jump in first. The big barrier is the narrow focus on achievement is measured by test scores at the expense of thinking more holistically about children, and the lack of resources. Some schools just don't have the resources. So that's the real question. How do we get the resources to the schools serving children the greatest need?
Thank you. Anyone? Thank you very much, Professor Noguera. Mr. Munoz, Dr. Damien.
Dr. Damien, would you like to go? No,
No, go ahead, go ahead.
no, just building off of Dr. Noguera, what he said here, access is one, but then confidence is another. Do parents have the confidence in certain health streams? Because we talked about this being generational. They're not used to going to the doctor all the time or sending their kids to the doctor all the time or having access to doctors or care or mental health professionals all the time. So I think there's another education piece, barrier that we have to overcome. And I'll let Dr. Damien clean it up.
Yeah, I mean, I would say that my colleagues are the experts when it comes to schools, but I would just say, as I mentioned earlier, in terms of workforce, having tried out to be an elementary school teacher and then giving up after a few months, when I was trying to decide what to do in terms of my professions. And I think that if this is one more thing that is added, similar to what we're seeing with the healthcare workforce, particularly in primary care, if this is one more thing that falls into the responsibility of teachers, in addition to what Dean Noguera noted in terms of this obsession over achievement and test scores, if it's one more thing that teachers have to do in terms of promoting health equity, I think without providing the proper resources or supports, I think will be challenging. I think another is really understanding, and this is something that Robert Boyd and I have written about in terms of what are we doing to support the pipeline early on in terms of different students who eventually want to enter and do health equity work. Like, how are we providing those opportunities early on? Because oftentimes it's not in terms of lack of interest in health equity, it's just lack of knowledge or awareness or access to really learn about the given issue.
Thank you. And there was one question directed to Professor Noguera. As a dean of the School of Education, what do you see as the challenges to creating an understanding of health equity at the intersection of health and education, but in the education workforce?
Again, it's the narrow focus. Schools have traditionally been just charged with addressing the academic needs of kids, and many schools struggle doing that. Think of how many students come away from school with barely functional literacy. Think about the ignorance in this country right now about science. The fact that so many Americans don't understand climate change or afraid of vaccines. You have to blame schools to some degree for failing. So I want to acknowledge that just taking care of the academics is a major charge. Now we're saying, in addition to academics, you got to think about health, right? You got to make sure the kids are healthy. And this is a lot to put on schools. So we have to be careful in how we think about it. We have to make sure that we're not asking teachers to be nurses and psychologists. They're not trained for that. We have to get nurses and psychologists and social workers into schools to reinforce the work of education. So it can't just be about asking those who are already overwhelmed to do more.
And thank you. And a question actually came in for both Dr. Noguera and Jose. What are we seeing, where are we seeing the kind of capacity building systems at both the district and community-wide levels that can support and develop the capacities that you both talked about? Where is it lacking, and what's the opportunity going forward?
Pedro, if you don't mind, I'll take that one first right here. So there's hundreds of communities right now, urban, suburban, and rural places, who are beginning to realize, especially through the pandemic, that we can't do this alone. We actually have to work more efficiently across our sectors. There were already places from the community school side where one of our local affiliates said that the mayor was asking the school district and the school district was asking community schools. So what were they asking for? They were asking for structures and systems already in place where it already had solid relationships and forms of communication back and forth to the households. So they could first find out who needs care, as Pedro talked about, who actually needs care, but also to learn what type of care is needed, and then begin to think of what type of solutions would it take necessary to mitigate the effects of what they were going through, whether that be poverty or medicine or isolation, mental health caused by isolation needs, so that the school itself and its partners, not to put it on the school, but the partners surrounding the school to begin to implement the different structures and processes and practices. So right now across the country, there's roughly near between 5,000 and 7,000 what we call community schools, but from the system side, there's nearing the 200 marks if I can count the names in the list of my spreadsheet that I have for community systems. What's lacking? It just takes the leaders. One person, I think, was the quote that Dr. Damien had used. I won't quote it exactly, but its intent was, just because now we have a little bit of diversity in leadership, we have people that look like us on the screen, doesn't mean that everything is solved. We need to really unleash the leadership across community. So the ability to actually share decision-making with local people who are actually in the circumstances that they're going through. And to think about that differently, because we don't want to put it just on the households and the parents. I'm a parent of 5. There's absolutely no way I could engage in all of my kids' school. But I did want a voice. I did have an opinion. So schools can think differently, but they don't have to do it alone. We have a person we call a community school coordinator that helps facilitate those conversations. So I think that's what's lacking a little bit. And Dr.
I would just add, again, if you think holistically, think about how many, it's estimated as many as 30% of kids who have trouble reading need eyeglasses. We have large numbers of kids who've never seen a dentist. Basic needs impact child development, impact academic performance. So, schools are the place where we can provide these services, but we've got to be more coordinated. And so what Jose is talking about happening, that's usually happening at the grassroots level. We can't wait for government to save us.
And thank you. And I have one more question. And unfortunately, we are really close to the end of the Q&A, and there are many questions in the Q&A box that we would actually get to. Tammy will give some directions in that afterwards. So we can only entertain one more question. And this came in. It's how do we empower kids to care about health for themselves and others? Just brief responses so we can pass on to Tammy after your response. And this is for all the panelists. How do we empower kids to care about health for themselves and also others?
I'll go first. You can integrate into the curriculum. You teach. Kids are naturally curious about their bodies, okay? So you integrate healthcare into the curriculum. Kids are curious about, for example, nutrition. You have to teach that early on about why too much sweets. Think how many kids are still drinking soda, too much sweets. You watch what they're eating in the morning. Make them conscious about what they're putting in their body and how they're growing, and kids will embrace it.
Dr. Damien?
Yeah, I will say one of our projects on youth homelessness in New Britain, Connecticut, we actually have young people be their best advocates. So actually having young people speak to their own peers about health, and particularly this is with regards to reproductive health and just overall wellness. And I think sometimes, again, not too different from us, being able to relate to other kids and feel that might be a safer space. I think it's so important to find those leaders among young people to be the best advocates instead of hearing from relatively young at heart people like ourselves.
Thank you. And I was just given the warning. We have to close off the session, and I would truly like to thank the panelists for your time, and also for sharing your wisdom, your ideas, your expertise, and also your personal experiences. And I'd also like to thank Mr. Robert Boyd and the staff and board of the School-Based Health Alliance. This work is extremely critical for kids and their families, and also as an extension to their communities. Our kids are our future also. And finally, and most importantly, I'd like to thank everyone for joining us today and for the engagement and also the amazing questions that came in. And unfortunately, we weren't able to respond to all. I would like to pass it back to Tammy Alexander now.
Thank you, everyone. I am overwhelmed a little bit with the information and the inspiration that I just heard, and I have lots of thoughts in my brain of how I'm going to use it. So we would like to ask you how you took the presentation today. There's 2 quick poll questions. Overall, how satisfied were you? And how confident that you're going to take this information away and apply it in your work, in your life, in your community, because as you've heard from everyone, this is more about just being in your job. It's way beyond that. So if you can take just a little bit of time to answer that, we have that ability to look at how you're feeling about what you just heard and where you might be inspired, if you feel confident to be inspired to take this someplace. I'll just be quiet for a minute. And Ufoma, when you are ready to close the poll, when we have a good amount of participants, I'll just let you close the poll and we can see the results. All right, so we have some great feedback on the presentation itself and the information that was received. And there's a diversity of how confident we are that we're going to be able to take this and do something with it. And that's okay. We're all going to be at different places and different times with this information. So if we could go to the last slide, I think it's the last slide. Oh, it's not second to last slide. Just some resources for you. These will be included in the slide deck that we send out to you. So you don't have to copy that down. Go to the next slide. I just want to, this is the important part here, people, is that we need a call to action. We need to take what we've heard today from each of the presenters, and we need to look for those opportunities that we can all work towards achieving health equity. The School-Based Health Alliance and Colgate and hopefully some other partners will continue to work together on developing more pathways for us all to come together to advance health equity. And as Robert mentioned at the very beginning of the hour, we have a conference in June and the foundation will be health equity and timing and being with our school partners and all the other community partners that we need. It's going to take time. It's going to take intention. This is a marathon, not a sprint. So all hands on deck. Let's see where we can make an impact. And I think Pedro said it well. We just need to all come together, systems and individuals, teams, et cetera, and start making this path count. Where can you contribute as individuals, as employees, as employers, as parents, and all walks of life? Where can you take this information and start to be inspired to find a place? It's going to take all of us to make this happen. So once again, thank you to the panelists, April Joy and Pedro and Jose, and especially Jillian for pulling this together and imparting your wisdom and your knowledge and your inspiration. And let's see how we can continue to work together. Thank you, everyone.